Thank you everyone for joining us. This is the second meeting on a series of 2 meetings of the Person-Centered Care Research Collaborative this week on supporting HIV prevention through programming and service delivery. Next slide. So a few housekeeping reminders. Please stay on mute unless you're presenting or the moderator calls on you until we get to the sort of discussion part, and then feel free to ask questions. If you'd like to provide a verbal comment, please raise your hand. Next slide. So this event has been organised by the IAS Person-Centered Care Program, which is advocating for integrated, inclusive and responsive healthcare services that focus on the changing needs, priorities and preferences of individuals and empowers them to demand services that respect their identities. Next slide. The Person-Centered Care Research Collaborative, The Person-Centered Care Research Collaborative has the mission of working collectively and efficiently at a global level to fill evidence gaps around person-centered care for people living with HIV or vulnerable to HIV acquisition. And this collaborative meets around 3 times a year to convene researchers, clients and providers who are championing evidence generation related to things like client-provider relationships, participatory approaches that value experts by lived experience, as well as specific research and policy gaps related to person-centered care within the HIV response. So the quality of the work included in the publication of the JIA supplement last September on person-centered care approaches to HIV prevention prompted us to want to convene a special series of meetings to hear from and connect each other, each of you of the co-author groups, in order to explore ongoing research gaps related to person-centered care prevention approaches. So today's moderator is one of the guest editors of the JIA supplement. Iskandar Azwa is an associate professor of infectious diseases at the University of Malaya, Kuala Lumpur in Malaysia. His research interests include HIV PrEP, implementation research among key populations, HIV resistance, and evaluation of newer HIV treatment strategies. So the floor is yours, Iskandar. Thank you.
So thanks, Emma, for that introduction and just really setting the scene. And, it gives me great pleasure to moderate the session, and certainly I will get along with my co-guest editor, Andrew. And, I just wanted to say I'm very new to this research collaborative as well. And, the opportunity to collaborate with IS was immensely a great opportunity. But, I think I've got to give it hands down to my co-editors, Andrew and Mary Claude, who are filled with energy throughout this whole process, and of course the IAS team. But really big thanks to Andrew, and I don't think I've had the chance to thank you for all the work that you sort of also took us above and beyond, and and timely responses to everybody as well, and congratulations on your publication in this supplement. I know a couple of faces, of course, on this call. So big hi to Carol and Ben, whom I think we met not too long ago in November, and it's good to take forward this discussion in a couple of future meetings as well, whether it be at the IAS or in APAC of this year, as well as in the Australian HIV conference as well. So I think I'm supposed to talk about the supplement objectives. And so as of the slide, the objectives, I think there was a slide before. Was there, Emma? Or have you covered that? Before that, I think? Yeah, so it's really today's objective, I'm sure Emma's touched on it, is really to convene a group of authors from this supplement, really to identify evidence-based strategies and identify what the future gaps are left with regards to person-centered HIV prevention for people at risk of HIV, really drawing evidence from the recent supplement which you all contributed to. Next slide, please. And so, as you know, the supplement was published in September of 2025. I don't know whether we're going to have a specific IAS session, Emma, on this. I had asked about it, but it's probably too far on at the moment for that, right? And yeah, but that's okay. So sometimes I think the IAS have had specific IAS either webinars or in-person dissemination sessions at the IS meetings. Anyways, coming back to the objectives of the supplement is to disseminate new evidence to scale up person-centered HIV prevention interventions. The scope included not just HIV prevention services, but also integration with other services, including that of hepatitis, tuberculosis, as well as sexual and reproductive health. And really the selection prioritized evaluation of novel strategies, demedicalization settings away from traditional care settings, and ways to overcome structural and legal barriers to improve access to prevention services and ensuring linkage to care. Next slide, please. And some of the key themes that have emerged, certainly around the evidence on person-centered HIV prevention, including and have been informed by some of these publications. Choice is central and highly valued by the persons seeking HIV-prevented care. We know that adherence to oral PrEP is suboptimal, and hopefully you'll hear also how digital tools can support adherence in today's collaborative. There needs to be ongoing discussions around how we diversify demand for long-acting PrEP formulations. The importance of statal neutral approach cannot be overemphasized, and the importance of integration with an inclusive primary healthcare system is important. And you'll also hear about how gender-affirming care and related services can be effective entry point for HIV prevention services, particularly around those to transgendered persons. Next slide, please. And so we will start with a presentation from Benjamin Bavington, and then we'll go on to Carol, and then Kantarida, and then Simran, and then my colleague will present a repertoire session from yesterday's session, focusing on Africa and North America, and then we'll all convene in a panel to discuss some research priorities, and then we'll speak amongst ourselves as well after that. So it's very informal, I guess. So we'd like to keep things very informal. So maybe if I could just introduce Ben first of all. So Benjamin Bavington is somebody I've known well from meetings. He's an excellent collaborator, has worked in the field of HIV prevention and research in Australia and internationally for 20 years. He's a senior research fellow and group leader at the Kirby Institute, University of New South Wales in Australia, really focusing on biomedical, behavioral, and epidemiological aspects of HIV prevention amongst gay, bisexual, and other men who have sex with men and trans women in Australia and the Asia Pacific region. And he'll be talking about sustained HIV prevention success in Australia through person-centered approaches. Thanks, Ben.
Thanks, Iskander. It's great to be here. So I think I might be doing something slightly different from what some of the other speakers are doing, because rather than speaking about a particular project or an example of person-centered care, the article that we wrote for this special issue, or the collection, was really about the Australian response and the way that person-centered prevention was built into our response. And the way that our response has incorporated these principles of person-centered prevention, even long before this term, person-centered care, was even invented. It's really been from the very beginning of the epidemic in our setting. So we sort of took the opportunity in the article to just discuss a few little insights, talk about some of the gaps, and then some of the research priorities as well. So next slide, please. So I think we all know what person-centered prevention is, so I can probably skip over this pretty easily. Prioritizes autonomy, preferences, lived experience. We've already talked about choice. But in simple terms for me, what it really means is that one size does not fit all. Different people want and need different prevention approaches at different times in their lives. And so we need to respect choice and agency. We need to understand that prevention options have to be tailored to changing needs. They have to respond to structural and social barriers, and there has to be a focus on dignity and human rights. Iskander's already mentioned the concept of choice, and so have I a couple of times. So these concepts of choice and convenience are sometimes dismissed by health systems and policymakers as nice to haves. that'd be great, but we can't afford that. Or that's not important because you've already got access to this over here. But really, choice is just so critically important, and to making sure that people have access to the prevention tools that they need and want. So choice today is often discussed in terms of PrEP products. That's mostly where I'm hearing it these days. But it's really much broader than that. Choice can apply to what prevention tools people use. Obviously, combination prevention doesn't just include PrEP, where they can access those tools and services, who provides those services and tools, and where they are available. So next slide, please. So Australia has achieved substantial success in HIV prevention. So some examples are that among Australian-born gay and bisexual men, HIV diagnoses have declined dramatically over the past decade, which reflects a combination of very high treatment coverage and viral suppression, together with one of the highest uptakes or concentrations of PrEP in the world, amongst particularly our population of gay and bisexual men. In some inner city areas of our large capital cities, we've been able to show that HIV incidence is reaching a level that is basically at the level of the UNAIDS 2030 targets of a 90% reduction from 2010 levels. That's already basically been achieved in some of the centers of our cities. But progress has been uneven. Diagnoses have declined more than half in Australian-born men, but they've increased by over 50% among migrant gay and bisexual men. We've also seen geographic inequities start to emerge. So outside of the inner city areas, in more disadvantaged suburbs, where access to services was more limited, where socioeconomic status is lower, and cultural diversity is greater. So these disparities highlight why we really need person-centered prevention approaches and differentiated service delivery. Next slide, please. So there are several features of the Australian response that align closely with these principles. So the first is what we term in Australia the partnership approach, which is the idea that you bring together communities, researchers, clinicians, policymakers, governments, and even sometimes industry. You bring them all together to make decisions about how things are going to be done. And when we talk in international fora about this concept of the partnership, I think sometimes people might roll their eyes a little bit like, yeah, everybody does that. But I really mean it. This is like a really, really genuine thing where all these actors or players are at the table pretty much for every important decision. So you can really see it in the way that every decision is made, the way that the strategies are written, the way that prevention approaches are deployed. They always involve all of the partners that I've just listed. Community organizations play a really, really central role, particularly in health promotion, peer education, and service delivery, because peer-based approaches allow prevention messaging to be much more responsive and culturally appropriate. In many cases, for gay and bisexual men, that means sexually explicit, than government campaigns could ever be. So the way that we sort of split up the roles means that everybody has a role that they play, but those roles are very different. We don't always have to agree with each other. We can have very robust disagreements with each other, but still manage to get things done. Secondly, Australia has taken a really two-way evidence-based approach. So we implement interventions that are supported by the science, like PrEP or treatment as prevention, but we also recognize that communities can come up and generate themselves important prevention strategies. And a good example is there is some of the risk reduction practices like negotiated safety and strategic positioning that emerged within gay communities, but then were later identified and studied by researchers, and then later again proven by epidemiologists to be effective forms of prevention. And this really reflects a pragmatic understanding that different people will engage with prevention in different ways. The last thing I just want to mention on this slide is pretty tricky for some other countries. We're very lucky that HIV is being treated as a fairly apolitical issue in our country. This has enabled the implementation of evidence-based and sometimes very controversial interventions like needle and syringe programs in the 1980s and even PrEP scale-up in the 2010s, which was not universally popular when we started it. But this success hasn't happened automatically. It reflects decades of sustained work by that HIV prevention partnership to make sure that it remains an apolitical issue. And we're always working on that and having to get the government to relearn that all the time. Next slide, please. So another key principle has been integrating HIV prevention into the broader health system rather than restricting it to specialized clinics or specialized services. Our policymakers are really not interested in these kind of small bespoke programs or services. They really want programs that can kind of come in and be implemented straight into the existing health system across the board pretty much all at once. That's the way we like to do things. We like to make big policy changes that just make a big change all at once. So the goal has been to make prevention and testing available wherever people seek care. So for example, the best example I can give is with really PrEP. In the rollout, we made the decision at the very beginning of PrEP rollout, which is quite different from many other countries, that any doctor in Australia could prescribe PrEP. And PrEP now is mostly not delivered through specialist services or specialist clinics. It's mostly just delivered through general practitioners in the community. And that's been quite a successful program. We've also got some other examples there about community-based testing services, needle and syringe programs being absolutely everywhere. There are literally thousands of needle and syringe programs across the country, and they're in pretty much every single community. And also HIV self-testing more recently being scaled up through pharmacies, online ordering, and vending machines. So integrating prevention across the health system also allows for more holistic care. So sexual health can be addressed alongside other health issues in a two-way loop. Opportunistic sexual health care can happen for those who are attending services for other reasons, like mental health or AOD or heart health or whatever it might be. And opportunistic care for other health problems can be given to those who are attending for sexual health care. So it's quite a good way to do holistic care. Next slide, please. Despite these strengths, of course, I've already mentioned a few of the limitations and challenges that remain. In some areas, we are sometimes what I consider to be a victim of our own success. And in some ways, we are falling behind other settings, many of them in Asia, in terms of innovative approaches, particularly to differentiated service delivery. We don't actually have very many differentiated services offered for PrEP. Outside of a few small pilots, we don't yet have widespread access to nurse-led PrEP, pharmacy PrEP, or peer-led services. We also currently have no access to long-acting PrEP products, despite strong evidence that that's what people want. And in fact, we can't even see a pathway towards getting access to these products because we've got 2 products now approved by our regulatory agency, but there is just no agreement that can be made between our government and the drug manufacturers to agree on a price to make this accessible to our community. And we've also just lastly there on the slide, we've got a limited understanding about what is driving some of the inequities. Next slide, please. So final slide here, just in terms of future research directions. So probably the thing that's most interesting to this group here today is the first dot point there, which is really a focus on implementing and evaluating new PrEP service delivery models. We are really trying to take this concept of demedicalization seriously. We did a huge policy review within the last couple of years about all the regulatory and policy barriers that are getting in the way of these new models of PrEP service delivery. And finally, we are starting to see some pilots get underway, a few of which my institute is leading, including nurse-led PrEP in sexual health services that doesn't require a doctor, pharmacy PrEP, which doesn't require a doctor's prescription, and even some really quite radical peer-to-peer PrEP delivery programs where the health system's just not even involved at all. We're not really sure how we're going to get that off the ground, but we're hoping we can get that off the ground over the next couple of years. We're also looking into telehealth models, particularly looking at improving the quality of private telehealth services. So we have all these telehealth services that exist, like these online private providers, but we've looked into it a little bit and found that they're providing generally pretty poor care. So we're working with a couple of different agencies to try to improve that quality. We're also evaluating a national program to provide free PrEP to temporary visa holders who are sort of excluded from our national medical healthcare insurance program. A second focus is addressing prevention inequities. We're doing qualitative research. We're looking at all these different peer-based models that we can get outside of the inner cities and really get into the suburbs and regions. And again, even though we can't really see a pathway forward for long-acting PrEP, we continue to do community preferences research and to conduct modeling studies to show the potential impact, particularly for those marginalized communities that long-acting PrEP could have. And we're hoping that those findings can inform ongoing advocacy for expanded PrEP options. So just to finish, we're ultimately sustaining progress towards HIV elimination in our context will require person-centered approaches that continue to innovate, expand PrEP prevention choice, and enact stronger efforts to address inequities. And I'll stop there. Thanks very much.
Thanks, Ben. We'll keep questions to the end in the panel discussion, if that's all right. So next up, we have Carol, I think. Yes, Carol. So Carol Strong is a professor in the Department of Public Health at National Cheng Kung University in Taiwan. Her research focuses largely on the behavioral and social aspects of HIV and STI prevention, with particular emphasis on HIV and STI particular emphasis on optimizing PrEP uptake, adherence, and long-term persistence across multiple modalities. Carol Strong, the floor is yours.
Thanks for the introduction, Iskandar, and thanks for having me here. So today I will share how we operationalize person-centered care in PrEP adherence using real-world mobile app data and machine learning based on our recent publication in the GIS. Next slide. So in Taiwan, both daily and event-driven PrEP are available. Event-driven is actually more preferred than daily regimen in Taiwan. However, event-driven PrEP regimen is not easy to follow. It requires two pills 2 to 24 hours before sex, and then one pill after 24 hours and another one after 24 hours. So it gets quite complicated, and people might be forgetting pills before or after sex. So, and also when you are given choices of regimen, people do switch. So in our prior cohort study, we found that in Taiwan, people switch regimen, and this does affect adherence. Particularly, we found that switching from daily to event-driven PrEP was associated with poorer adherence. Next slide. So this is why inspires us to develop uPrEP-U, a user-centered mobile app designed specifically for flexible PrEP dosing regimen for men who have sex with men in Taiwan, hoping to improve people's PrEP taking behavior. And this app allows you to record your PrEP intake and your sexual events. So basically your PrEP diary and sex diary, and sends reminder based on dosing regimen and anticipated sex. It also tracks whether users' sex events were protected by PrEP and log their dynamic dosing choices. So importantly, it supports decision-making rather than surveillance. Next slide. Person-centered care means recognizing that individuals have unique values, preferences, and behavioral patterns. This app operationalized person-centered care by capturing sexual context, tracking longitudinal prevention behavior, allowing flexible dosing, providing individualized feedback. So although it's digital, it aligns strongly with person-centered principles. Next slide. So our objective for the paper was simple. Can we use real-world app data to predict whether a specific sexual event was protected by correct PrEP use? For example, event-based attributes. So what happened at the specific event, the characteristics of each sexual event. And importantly, we want to know that does adding user-based attributes improve prediction compared to using only the event-based attributes. So what we want to know is that is protection determined by what happened at a single event or by the person's behavioral history over time? Next slide. Our outcome was whether PrEP was taken correctly for an anal sex event based on daily or event-driven dosing rules. Next slide. Yeah. So we built CapBoost machine learning models. Model 1 used only event-level attributes, and Model 2 builds on that. So it's on top of the event-based attributes. We also added 19 dynamic user-based longitudinal attributes. Next slide. We analyzed data from 198 users between January 2022 and May 2023. They logged 2,356 anal sex events. On average, the users spent 155 days and 19.5 hours on the app. The average number of sexual events for each person was 11.9. 70% were protected by correct PrEP use. And the machine learning model shows that Model 2, the one including user-based attributes, significantly outperformed the model with only event-level attributes. So this tells us that adherence is not just about what happened at the event. but reflects a longitudinal behavioral pattern. Next slide. So next we want to ask, can we narrow this down to a smaller set of core predictors? And our most parsimonious model used just 5 variables: cumulative times of taking PrEP, age, how long people has been using this app, proportion of using condom, and proportion of having sex events with a partner who was HIV negative and not on PrEP. So the strongest predictor here was cumulative times of taking PrEP, and this suggests a learning curve. So the longer you have been taking PrEP, you are less likely to forget to take pills. Adherence improves with accumulated experience. So we think that using a mobile app to regularly track your behavior and actually seeing it reflected back to you might be able to help you to reinforce PrEP adherence. And when people can recognize their own patterns, they are in a much better position to adjust early and take timely prevention steps. Next slide. So what we are seeing here are not just isolated sexual events. These patterns reflect more stable habits and prevention choices within the Taiwanese context. If we understand these recurring patterns, we can build better predictive models and design more person-centered interventions. In practice, that would mean integrating these insights into clinical consultations or digital tools, helping people to make more timely and informed HIV prevention decisions. Moving forward, we want to expand beyond PrEP adherence alone. The next step is to focus on person-centered harm reduction, for example, looking at how sexual health and substance use intersect, and particularly in the chemsex context. The broader goal here is to move forward person-centered care in digital prevention. Instead of giving everyone the same standard reminders, the tool would adapt to what's actually happening in someone's real life. Next slide. Thank you very much, and looking forward for the discussion.
Thanks, Carol. We'll keep questions to the end. So the next one up is Kantarida Sri Panit Kuichai. Is a clinical researcher from Thailand working at the intersection of HIV prevention, digital health, and youth engagement. She's a lecturer at Siriraj Hospital, Mahidol University, where she also provides care to over 2,000 patients. And really her publication was based on the Stand By You model as a person-centered online HIV self-screening and counseling model, reaching first-time testers and underserved youth, sorry, not undeserved, underserved youth. Kantarida, the floor is yours. Thank you very much.
Okay, thank you for convening this meeting. Sorry, and giving me an opportunity to present today. Today, I will share implementation evidence from Thailand on how person-centered online HIV self-testing model can operationalize prevention in real-world service delivery. This is not a technology story, it's a service design story about access, autonomy, and measurable prevention impact. Why does matter now? To frame this work, Thailand has approximately 500,000 people living with HIV and more than 8,000 new infections annually. Despite national HIV incidence has declined over the past decade, young people remain disproportionately affected, with nearly half of new HIV acquisition occurring among youth. Those who aged 15 to 24, and roughly 2/3 occur among key population, including men who have sex with men and TG and non-binary genders. So why effective tool exists like HIV self-testing, PrEP, ART, access barrier persists. Stigma, confidentiality concern, and administrative friction continue to limit uptake. HIV self-testing is included in the Universal Health Coverage Package in Thailand, yet access may still require pre-registration with a national ID, a designated facility, which can discourage uptake due to privacy concerns. Availability does not automatically translate into accessibility. We therefore ask, can an anonymous, youth-friendly online first model reach adolescents and young adults at scale, deliver HIV self-testing nationwide, support linkage to treatment and prevention, and maintain person-centered principles? So we conducted a retrospective observational analysis of program data from August 2022 to February 2024. The Stand My You program operates through Line and a website. Demand is generated through TikTok influencers targeting youth audience. Clients complete an online risk assessment, receive tailored recommendations, and can request HIV self-test kits delivered nationwide or across all 77 provinces. The system combines a chatbot with trained human counselors, providing confidential text-based counseling with instant response. Clients submit the result online and receive support for confirmatory testing, ART, PrEP, linkage as needed. Access is anonymous and no ID person ID requirement. During the study period, the platform recorded over 43,000 unique views and served 8,863 clients. 76% were under age 30 and more than half were first-time testers. That matters because first-time testing is often where stigma, fear, uncertainty are most intense, and where person-centered design can have the biggest impact. Next slide, please. We distributed 9,200 HIV self-test kits nationwide. 82% of clients submitted their result. In the world of implementation, 82% is not just a statistic. It signals that the model reduced friction. The pathway was understandable, convenient, and sufficiently supportive to compete. Among submitted results, 3.6% were reactive. 60% of those were successfully linked to confirmatory testing and care. Among those receiving confirmatory testing, 90% were confirmed HIV positive. So this 3.6% matters. Based on military conscript surveillance data, 3.6% reactive rate is more than 7 times higher than background preference, which observed more likely among clients identifying as LGBTQ, those with history of STI, and those reporting receiving money for sex. Meanwhile, prior HIV testing history and PrEP use were associated with reduced odds of reactive result. This suggests we are not simply scaling testing volume, we are reaching individuals at substantial elevated risk who might otherwise remain outside facility-based testing and connect them to care. However, next slide please. The cascade also reveals a core challenge. Anonymity increased uptake, particularly among youth and key population, but anonymity limits our ability to actively trace and re-engage individuals after a reactive result. Some clients were lost to follow-up due to non-response or communication blocking. This reflects a key tension in person-centered prevention. Privacy expands access, but it complicates linkage science. The question is not whether anonymity works, it clearly does, but how to strengthen follow-up without compromising autonomy. In our model, counselors are present not only to deliver results, but to help people interpret them, manage anxiety, and choose the next step at their own pace. The platform also enables rapid prevention integration. Client reporting recent exposure requested PrEP counseling were linked to services. This assessment informed tailored prevention recommendations include PrEP referral, This demonstrates that digital platforms can move beyond diagnosis and function as differentiated prevention delivery system, especially when timing is critical. Next slide, please. From an implementation perspective, this model operationalizes four principles: anonymity when needed, rapid information without judgment, risk-based differentiation, human support that respects autonomy. Standby U was built to meet young people in the channels they use, offer home delivery without identity requirements, and provide counseling that is private, text-based, and consistent. These principles are globally relevant, especially in settings where clinic-based stigma and administrative requirements can undermine access, even when policies say services are available. And importantly, this is not only about diagnosing HIV, it's also about supporting people who test negative but remain at risk and connecting them to PrEP and prevention supplies to service and that feel safe and affirming. What this study showing that person-centered design is implementable and measurable, but scaling it responsibly requires solving four core challenges. How to validate metrics for person-centered experience beyond satisfaction. How to strengthen linkage without undermining privacy. How to reduce structural friction at scale, and how to scale up sustainability. Our next phase focuses on improving measurement, refining linkage strategy, optimizing differentiated prevention pathway, and aligning with national financing system. Because ultimately, person-centered prevention is not a soft concept, it's the architecture of effective HIV prevention delivery. Thank you, and I'm looking forward to the discussion.
Thanks very much, Kantarida. We'll move on to the next speaker, and next speaker is Simran Sheikh Barucha. He is a very nationally respected public health and governance leader in India, whose work has shaped policies, empowered communities, and influenced dialogues from grassroots collectives to global platforms. Simran brings over 20 years of lived experience and leadership in advancing equity, dignity, and systems change across India and globe. And he'll be talking about his publication, Laser Hair Removal to Antiretrovirals. Thank you, Simran.
Thank you so much. Thank you so much. And I wish you could have pronounced my preferred pronouns, which are she and hers, which is absolutely okay. I really do face it most of the time. But let's go ahead.
I apologize for that.
No worries.
Apologies.
Absolutely. No worries. No worries. So this is a beautiful research article that we are presenting today on behalf of the entire trans community in India. This is not very, very old study. It is quite recent study. And before I really dwell into it, it's a clinical care model specifically designed for transgender individuals. Can we go to the next slide, please? So let me set the background as an introduction. Transgender people, we all know, globally face systematically, not incidentally, barriers to healthcare. These barriers are very much structural, legal, social, psychological, interlocking, and mutually reinforcing. In India, transgender women continue to experience disproportionate HIV burden and limited access to gender-affirming care despite decades of advocacy. Stigma and discrimination, violence, and documentation barriers create a hostile care environment, pushing people away from their essential needs of services. This research emerges from a simple question: what happens when we design healthcare around dignity, identity, and community leadership? Can we go to the next slide, please? Let me remind you all, Mitra is a Hindi word, and which means friends, which means colleague. So that's why this beautiful name comes to this clinic, which we truly which is truly the essence of what we actually had dreamt of. So why there is a need of this Mitra Clinic? So Mitra Clinic was actually launched to bridge the implementation gap between the policy intent and the lived realities. They are community owned, which means community sits on the driving seat. It is led by the community and internationally designed to counter the barriers highlighted earlier, which was stigma and discrimination. The model was built on very much on three pillars. First is the community ownership, ensuring trust, safety, and cultural competency. Integrating services while reducing the fragmentation and making care completely seamless. Third, of course, was the gender affirming person-centric care, placing dignity and identity at the center of every interaction. These clinics are just not service pointers, they are a safe space, identity affirming space, and trust building space. Can we go to the next slide? While we talk about the clientele flow, it is completely designed to a non-hierarchical, warm and welcoming space, unlike the traditional clinic environment or the governmental hospital environments. The peer navigator out here plays a very crucial and a central role in reducing anxiety, supporting disclosures, and guiding the clients through its services. Every step from registration to counseling to clinical care is structured to minimize the stigma and maximize the comfort of the transgender folks who visit these clinics. Can we go to the next slide? While we talk about the very important component, that's the services provided within this clinics, let us remember that this is a one-stop center. It's a single window access to a wide spectrum of services that the transgender women often have to navigate separately. Integrating healthcare includes HIV testing, treatment, PrEP, gender affirmation HRTs, referral for surgeries, etc. Expanding counseling addresses mental health and identity affirmation and psychosocial stereotypes area which is often neglected in the public health systems. Legal and social protection linkages help the client access identity documents, the welfare schemes which are entitled by the government, the entitlements which are long awaited for the overall well-being of this community. And as I said, the staffing model is intentionally kept as a community-led, ensuring representation, trust, and lived experience expertise within the clinical premises. Now, as we go to the next slide, which will talk about the numbers, can we go? Yes, which will talk about the numbers, the impact. Let us look at this the three clinical that it served with more than 5,200 unique clients, which accessed various services over the span of 3 years, demonstrating high demand and trust within the clinic. 75% of this unique clients came for gender affirming care, showing that gender affirming services are a powerful entry pointers into a broader health system for trans folks. 53% access laser hair removal, highlighting how affirming services drive the engagement. 70% had never accessed public HIV services before, showing that the Mitra's role in reaching to the unreached is solved out here. Now, when we talk about the HIV outcomes, which are again very strong, 62% testing were uptake. There was a 62% testing uptakes. 6% was the new yield among the diagnosis, and 98% viral separation was found among those with available data. Now, when we look into the PrEP interest and the uptakes, which are significantly high, out of 575 eligible clients, 378 were consistently for more than 3 months on PrEP. This is a significant achievement in a population historically excluded from PrEP programming. Coming into the next slide as the lessons learned, the critical implementation lessons learned. Yes, the fragmented confirmatory testing pathways created little delays and dropouts, highlighting the need for a system-level integration. Disclosure concerns remain a major barrier, even in the safe space. Clients fear stigma and in external system. Loss between the community and the community clinic and the public antiretroviral centers shows that the person-centered care must be extended beyond the clinical walls. And the overarching lessons that we really learned from this is community-led models works better for the broader health system, which evolves to match with them. And when I come to the conclusion part, this typical model actually really shows that Mitra Clinic models shows that the gender-affirming services are not add-ons. They are the foundations of the health engagement specifically for transgender individuals. Community-led, person-centric models, building trust, improves health retention and strengthens the HIV outcomes. When care is affirming, respectful, and integrated, trans people engage deeply and consistently. This model offers a scalable, equitable pathways for India and countries to transform transgender health. With that, I say thank you. Open to questions maybe towards the end.
Yeah, thank you very much. We'll leave questions as part of the panel discussion, if that's okay. So now I invite Andrew. Thank you very much, Andrew. Andrew is head of the Infectious Disease Institute, Kanzagati at Makerere University, Uganda. His current research focuses on developing methods to build self-efficacy and empowerment, increasing antiretroviral therapy adherence, and reducing sexual and HIV-related vulnerabilities among key populations in Uganda through the use of combination HIV prevention tools. And Andrew's just going to do a rapporteur feedback from the meeting yesterday, which was focusing on areas of Africa and North America. Thank you, Andrew.
Thank you, Skander. So the program yesterday focused on presentations or publications in the supplement from Africa and North America. And today we are focused on Asia. Next slide. So the discussion focused around scaling up HIV prevention for those who need it most, as we're doing today, using an integrated approach. Next slide. So reaching the last mile, people who are still not in care or in care but are not virally suppressed, really needs people-centered scaling up. And we discussed 3 broad approaches, starting with peer navigation, where we had a presentation from South Africa, where peers were able to reach adolescents and young people through prevention and care pathways, and reduce their structural and social barriers to engagement, able to increase uptake of sexual and reproductive health services, including HIV testing and PrEP. Additionally, we discussed the importance of dynamic choice, giving people a choice of prevention products, as Benjamin highlighted in the first talk, that really aligned with what they need and and their circumstances. We had a talk from Canada where people who are offered safer services, such as needle and syringe programs and opioid agonist therapy, were able to re-engage in care after you first met their substance use needs. And then thereafter, the HIV needs were able to be taken care of. And you've just had similar thing from India, where once you offer gender affirming care, then people engage in HIV care. And then as the talks have also highlighted today, focusing on community delivery, where you take services to where people are, and decentralized care beyond the clinic. The challenge with this is that the long-acting injectables are now re-medicalizing PrEP and taking it back into the facilities. It would be important that we do not concentrate PrEP, feature long-acting PrEP just in clinics where some people are not comfortable to attend. A presentation on using digital health data to facilitate linkage to care and monitor scale up and implementation. We noted that only 2 countries globally could calculate the linkage to prevention. Many countries can estimate linkage to care, but linkage to prevention is not monitored. And one of the things that I noted was that there's currently no global monitoring mechanism for post-exposure prophylaxis. Next. So the digital health presentation focused on areas that we have better data for, including testing, condoms, PrEP, and PEP, and vertical transmission, but limited data on needle and syringe programs, opioid agonist therapy, behavior indicator data, and linkage to prevention metrics. And also, like I just said, no monitoring systems for PEP. So these are things that we need to close, these gaps, if we're to get to 95, 95, 95, especially for hard to reach populations, the key populations who have been driven underground because of adverse legislation as well as funding cuts. We heard about long-acting PrEP in the setting of maternal health, especially for pregnant and postpartum women, and integrating that into existing antenatal and postnatal care is something that we urgently need to do. A new mother has very many priorities, and PrEP may not be at the top of her list. So understanding how we can integrate long-acting PrEP into routine care would be important, but also doing monitoring and pharmacovigilance. Second, for postpartum, identifying differentiated delivery models that could really mitigate a very sharp decline in PrEP continuation we see during these periods when moms are focused on the welfare of the infant and sometimes neglect their own health, and especially during the period when they're reinitiating sexual activity. Then using digital and artificial intelligence tools to improve our risk assessment, inform product choice, and help with provider training. And as we heard from Taiwan, also support adherence. And then lastly, generating actionable evidence and cost effectiveness to make sure that we can scale up long-acting PrEP, which is currently too expensive for those that need it most, and is mostly now focused in the global north in terms of rollout. Next. So we also discussed how we could integrate PrEP into sexual and reproductive health services, combining it with social care and to address multiple needs in a single contract with services. So like I said, in the context of harm reduction services, and now we heard from India, transgender care. Task shifting to peers is important, but you also need to provide oversight so that we do not have harms from delivery of interventions because of lack of oversight. Empowerment through choice that has been highlighted today, and integration in primary care, and breaking down the silos between sexual and reproductive health and PEP and PrEP and ART, which are often delivered in standalone settings or clinics. And integration would be able to reduce those barriers to care. Next. So for people who use drugs, as we said in Canada, future directions for this research looking at the cascade of care, providing safer supply modalities as the population transitions away from injecting use to smokable oral opioids, and focusing on differential impact on HIV and hepatitis C outcomes across modalities. Now, the challenge with this is that there is defunding of the programs and scaling back of harm reduction. And so we need to monitor treatment interruptions and reduce the uptake of testing and make sure that we continue to reduce incidence in the population that uses drugs. The challenge is that with the cutbacks, there's also reduced funding for monitoring and data collection. And so it may take a while before we can document the harms that have been done to communities worldwide. Next. So the discussion concluded with a discussion on strengthening digital data infrastructure. Like I said, prioritizing linkage to care metric, to prevention metrics, and closing data gaps for lead and syringe programs and opioid agonist programs. Advancing long-acting PrEP, not just in maternal settings, but also for other populations. Integration of primary care, and also protecting harm reduction services that are being defunded in certain settings. Next. Right, so I want to thank you all. It's good to see you on the screen, and wishing you the best in your future endeavors as you continue to expand the agenda for person-centered care. Back to you, Iskander.
Okay, thanks very much, Andrew. So now I think we have about, well, we're exactly on almost, we're 5 minutes a bit late, but we're about 15 to 17 minutes of panel discussions. So I'll start this, but feel free to chime in. And Andrew, please as well chime in as well as my co-moderator. Maybe I'll start with Ben. So Ben, thank you for your last slide. You mentioned some of the ways in which Australia can move forward, particularly in terms of its research agenda, is thinking about diversifying PrEP service delivery models. Now, firstly, Australia has a very successful primary healthcare system, which you clearly emphasize in your viewpoint. Maybe you could speak about that. You did talk about that in your publication. You did speak, but maybe could you just spend a couple more minutes on that, on the success of the primary healthcare system in terms of service integration for a couple of our co-presenters here. And I was also interested, maybe if you could just start with that. And I was also interested in the other service delivery models, particularly the pharmacy-led PrEP service delivery model without a doctor's prescription, and how you're going to get around that so that, a country like Malaysia, which is also heading towards that, could learn potentially from you.
I think you're actually ahead of us on that, Iskander. We'll probably be looking to you a little bit. And a lot of those details, particularly on pharmacy PrEP, are still a little bit unclear. What we're I'll start with the pharmacy bit because I think it's where my brain is right now. I think where we're really trying to go is what's happening at the government level within Australia, and also at the national government, also at different state governments, is a real interest in expanding the scope of practice for pharmacists. It's happening across the board. It hasn't really been applied too much yet to sexual health, and certainly not to HIV. It's a little bit with sexual health. So now contraception is being introduced into pharmacies without a doctor's script being needed, and also UTI infections. You can now get treatment for that without needing to go to a doctor, whereas previously you had to. So there's this real interest in expanding that scope of practice, because while we do have a very, very effective primary healthcare system in our country that's very well subsidized by our national medical insurance scheme, it is under a lot of pressure. And I might even go as far as to say it's actually in a little bit of crisis. People are finding it harder to get appointments. And we have this thing that's called bulk billing, which essentially means the patient pays nothing. And it's becoming harder and harder for patients to actually turn up to a clinic and not have to pay a gap fee. So we're really, the government's really interested in this expansion of the scope of practice. The challenge with PrEP, of course, is you need to really have some confidence that the person is HIV negative before you put them onto PrEP. It's a bit different from contraception and some of the other things that have now been rolled out in pharmacies. So what we're probably looking at is a model where a self-test is all that's required. I think personally, and I think our PrEP guidelines panel agrees with this as well, that we're being too conservative with PrEP. I really think we are. This is a very safe medication. And in most parts of the world, certainly in Australia, most people who are HIV positive now are not using TDF-FTC for treatment anymore. So even if there does end up being a little bit of resistance that gets caused by someone who's actually HIV positive starting PrEP, they might be on it for a few weeks, even a few months. The potential of the resistance and the harm that that could do to public health, I think, is a little bit lower than the potential risk of not being able to give someone PrEP when they need it, immediately when they need it. And I think in Australia, at least, I think we're starting to move a little bit towards that direction. One thing that we are some of us are trying to push for, some of the advocates are trying to push for, is actually the much more radical idea of removing PrEP from what we call the Schedule 85, which means you need a doctor's prescription from the chemist, to actually just making it an over-the-counter medicine that anyone could just walk into a pharmacy and pick it up. That's very controversial at this point, but honestly, I really believe in 15 years' time, there'll probably be a lot of places that are doing that because this drug, it's just so safe, it's so effective, and I think the public health benefits potentially outweigh some of the concerns. But I'm not a doctor, so I know doctors get very worried when we start talking about these really more radical approaches to PrEP access.
No, but in fact, we had that debate in APEC as well. I don't know whether you were there that year regarding the need for a doctor's prescription, and pharmacy-led PrEP was, one of the examples they had given. Now, on that note, and I want to give the other presenters a chance to speak, but Andrew, I know I'm putting you on the spot, but I know you have some experience because Africa sort of leads the way, particularly, I think, if I'm not mistaken, Kenya and maybe Uganda as well, and South Africa lead on a lot of pharmacy-led PrEP. Do you have any key lessons learned from implementation there, maybe for Benjamin and I in our respective countries?
Yeah, thank you, Iskander. I can relate to what Benjamin is saying. Clinicians like to have control. And when you say decentralization, that's hard. It's easier in our setting, I guess, because we have much larger populations and clinicians are just simply overwhelmed. But in the pharmacy PrEP models that have been rolled out in Kenya, there is still clinician oversight. There was engagement with the national government, with the pharmacy control board, and with private, because most of the pharmacies are private. It was training. Not all of them were willing because it's a cost to delivering the service. But there's always clinician oversight. So if they're stuck, you can call and ask people to, you ask for if you have any questions, for a clinician to help. What we're finding is that the population that go to pharmacies is different from that goes to clinics. Pharmacies, the population tends to be more middle class, more male, people who are coming home from work, don't have time to go and queue in a clinic for 3-4 hours and drive by a pharmacy and pick up their supplies. Additional differentiated models, including telehealth, where you can order PrEP online and have it delivered to you by a motorcycle courier. That's also very popular. Started around during the COVID time and has continued to be rolled out, as well as consultations within the pharmacy. Some are enthusiastic about it and some are not. So testing models where users pay a fee or where you pay the fee, the various models. But what we're finding is that you're able to reach younger men, and the timing of uptake is also different in that people tend to come in around the weekends. So the morning after Friday, so it's a Saturday morning, Sunday morning, Monday morning, and twinning that with emergency contraception as well has proved particularly effective.
Thanks very much for your insights, Andrew. Kantarida, if I could move to you, Kantarida. Hi. I found your HIV self-testing platform extremely impressive. In fact, when you said some things like, particularly some of the things, you reach 50% first-time HIV testers, 82% results were you managed to trace back 82% results. Correct me if I'm wrong, which I think it's has been very difficult with a lot of online platforms, for clients to actually return their results. So I just wanted to maybe identify your successes there. You mentioned it briefly, but how did you manage to get 82% return rates of HIV self-testing results? I thought that was excellent. You also, I think, underplayed your linkage to care. 60.2% linkage to care was actually very high. So maybe just that first question, and maybe the gap here was your linkage to prevention metrics, and how you intend to improve that, or how could you potentially improve that?
Yeah, thank you for your question. Did you hear me well?
Yes, can hear you perfectly.
Yeah. So for first question, I think like their success come from the teams, the counselor team who ask them about their result and provide them the method after they send the results. We have instant message that follow up everyone that who got the test by mail, 3 day and 5 day and 7 days. And then if they feel it useful for telling us about the results, so they tell us. That's why it's very hard and complete, and I think it is challenging for the team to follow up them. However, when they know about PrEP, if they stay negative, so they sometimes they send us the result um maybe sometime not in that week, maybe a month later, or maybe 6 months later. However, another successful method is about we tell them about we will give their second time of cell test delivery 3 months later. But if they send us the result of the photo of the testing, so we can give them new in 1 month, something like that strategy will help them to tell us about the result better. So that's why 80 is really high for our project as well, because we before we implementation this, it's only low, maybe 60 to 70. However, for the second question is about linkage to care. It's really hard for us as well. There are many complicated issue about blocking, because in Thailand we use official, and people can block when they feel not interested anymore or about privacy. So we have high blocking rate as well. It's about 7%. For linkage to care, if some people read but not respond, sometimes they just need time for themselves to go to their facility-based clinic and then confirm by themselves, and then receive the ART, and then they come back and tell us about how successful program we are. That thank you for reaching them to the facility care. However, we have the same person counselor for follow up with all the positivity, case manager as well, because now today we have more than 700 people positive, and then the counselor nurse who taking care of this project about follow up the patient. I think that is one of the key success of our project. Sorry
Thanks.
for
No, that's fine. And then the linkage to prevention, to PrEP, can you reinforce that from an online testing platform?
Yeah, that is the hardest thing in my project. I will tell that, because now today we have high emergency PrEP usage more than PrEP linkage. We have only 40 people for PrEP linkage care in that time. I think for PrEP it's very challenging at initiation, but it's more challenging when after initiation at 1 month and 3 months, because even facility based still have loss of half of people after continuation phase. So I think the thing that Carol present, using the app to promote prep linkage and continuation phase is quite interesting. Thank you.
Thanks very much, Kantarida. Carol, if I may, and you feel free to respond as well to Kantarida, or we can leave it until the session after. I didn't realize you were doing maybe a lot of work around mHealth, and your publication was very, very impressive. One of the things I tend to think about around mHealth and is how you get users to engage it eventually into the larger health systems, so that it's not just an app which is used by the patient, but that other healthcare providers can benefit as well. And as well as maybe thinking about mHealth models and sustainability of mHealth models in terms of costing. So two questions around there, and more for us to learn some of these implementation outcomes.
Thanks for the question. And I also want to respond a little bit to the, I think, earlier discussion on decentralization. I'm very jealous of what you all have that you could do the decentralization part, because in Taiwan is totally like opposite from them. So that's why we are developing digital solutions, because we basically, it's impossible to have pharmacy-led or other different type of differentiated service delivery in Taiwan. It's very constrained. And so many people, or a few people now, are developing digital or mHealth solutions for PrEP, either in linkage to care or improving adherence. And back then, what inspires me to do this is really this quite unique situation that we have such a high number of people using event-driven PrEP. And we did not publish this, but we actually have a good proportion of people using informal PrEP. So people just get PrEP from friends or here and there. And so what we are more concerned about is like this difficult dosing regimen and whether people are able to follow this. And then our study showed that they could. That's what inspires me to do an mHealth tool on adherence, particularly, but not about the service providers. We actually tried that. So we actually had a chatbot that we did not publish. So we're trying to decrease the burden for the PrEP navigators in Taiwan. So people who work as a PrEP navigators in Taiwan are mostly HIV case managers as well. So they have like, each person might have hundreds. I visited Malaysian hospital last time in your ChemSec symposium, and we also learned that your case manager have to take care of lots of people, and it's very similar in Taiwan. So our goal at that time was like, can we develop a chatbot that they can help answer those questions that everyone's asking, that doesn't need to burden the case manager to answer midnight or 3 a.m. or something like that. And we tried that, but we realized it's very hard to promote that into Taiwan system, because every hospital has their own way or platform of communication to their users. So they basically don't want to replace that. And they also feel like there are questions that cannot be answered by chatbot, because people will ask very random question, like begging the PrEP navigators to give them a go. So those are not something that machine can replace. So we also try to do something with healthcare providers, but on at least on my end, we have not successfully implemented that, at least. And one of the reason is that current system already has different platforms, and then it's hard to ask people to replace the system or subsidize with a different one. And about the cost, yes. So far, I'm still trying to use some research grant to hang on to this app. It doesn't cost much to run right now, but still like the database and storing. And another cost is how do we keep marketing or promoting the use for the app? So basically app adherence, like people would like to stay there. So once in a while, we need to come up with some coupons or, incentives for people to stay there. Yeah, that's so it's been like 4 years. I'm still hanging there, but have not yet think of a more sustainable way.
Right. Okay. Thank you very much. I think also, Carol, never say never. What may be a problem may not be a problem. We understand the problems around inflexibilities of health systems, and some countries have probably more of it than that. I mean, Malaysia is also very inflexible when it comes to it, but I think it is possible, particularly in the HIV field. I mean, it's led on a lot of innovations and also leading to a lot of flexibilities around the health systems. Thank you. Now, I just want to make sure I get this correct. Your preferred name is Barucha, is that right?
You can call me Simran.
Simran. Okay, I apologize.
Right.
Okay, Simran. Okay. Thank you for your presentation. It was one of also the most enjoyable publications that I certainly read. You highlighted community leadership and ownership of the emitter clinics, and certainly gender affirming care as a pathway to access, particularly access for healthcare interventions for transgendered women. Now, and I just want to see, I think one of the gaps, of course, is declining community leadership and ownership with as the HIV era goes on. I think people's voices are sometimes not often heard as much as they should be, and clear examples of particularly around demedicalized delivery service deliveries, and also more recently around long-acting PrEP. And Benjamin could also add to that. You can hear his frustration when he always talks around this, particularly in countries where we expect they should be leading the way. So in your setting, the community leadership and ownership involves very much the community at the center, but you still have doctors in presumably prescribing and dispensing PrEP. Is that right? So how far do you push the community leadership in the scale up of these clinics, and in terms of ensuring that they are properly trained, certified, and more importantly, reimbursed?
Thank you. That's a very, very beautiful question. So let me remind you, I did mention a word in my presentation called community at the driving seat. By that, I really meant even my doctors are from the community. So we had doctors from the transgender community who were sitting and leading it. And you correctly mentioned it is a time where we really see, with so fast, rapidly things moving around us, it is quite difficult to hold on to our leadership, hold on to our premises. But that's also a beautiful way of understanding that as the evolving process is going on, we also need to evolve. So I give you a very best and a good example, and I'm sure my colleague Dr. Partha is been over here. Even he could sort of pitch in. India has a national guidelines on PrEP. However, its implementation is yet not implemented because it is associated with the cost, and currently the government is not in a provision to sort of provide with resources on PrEP. As compared to HIV medicines, because HIV medicines in this mini continent called India is free of cost, and it is accessible through the ART centers. Comparatively, PrEP is not. PrEP is still something that you go and you buy it. It is not in our insurance. It is not available free of cost. So it is related with cost. Yet we see a huge number in India, specifically in India, among all the key population who are vulnerable to HIV, and also towards the general population, the youth of this country, whose intake towards PrEP is really more. This also significantly tells us that yes, PrEP can be affordable, and PrEP can be taken over the counters by paying up. And if you have a a valid prescription, you can pick it up from the pharmaceutical medical stores. It also tells us that it is a less burdened towards the government resources. So it's how you view a coin from both the angles and how you see that. It's completely on us. How do we reflect on that? But honestly speaking, does it have an implication on the overall yield, the overall new HIV cases? Yes and no. And yes, because of multiple factors, and no, because of multiple factors. When I say multiple factors, PrEP alone is not the responsible or the, or the only precaution method. Of course, there are condoms, there are many other prevention tools which are equally important. But yes, PrEP act as a double protection, and which is considered to be little better. But yet India is little behind on that system. I think I've answered you. I don't know.
More or less, yes. I'd like to invite Dr. Parta. Is
Yes.
he your colleague, to maybe just add a couple of
Yes.
comments?
Yeah, thank you, Simran. Thank you, Iskander. So that's a very nice point you kind of brought on the table. We kind of in the project Accelerate, where we worked, as well as in the entire the Indian program, we strongly depend on the community monitoring, community mentoring, and community leadership and everything. But when it comes to prescription and laboratory testing, definitely the legalities are around. We are not able to break that. So for that, how we are operating is, we are not working on a vertical community structure, but we are shadowing the specialists with the community support. Like, for example, endocrinologist shadowed by a trained community person, a surgeon shadowed by the trained transgender community person, so that the counseling, the trust building, the lived experience, everything can be shared. Whereas the specialist will kind of give the core technicalities, rather than spending his or her time more on the counseling part. So that way we integrate community into the technicalities through the integration and collaboration between specialists and our community members. Thank you, Iskander.
Right. I think one of the barriers sometimes, often with certainly in areas of HIV prevention, and no disrespect, I'm largely a clinician, but I think is moving towards these differentiated service delivery models is to get the clinician as much out of the picture as possible, and ways of thinking around that, because sometimes they're often a barrier, right? And I mean that very humbly as a clinician, whether it's pharmacy-led model or whether it's community-led models are clearly examples of that. And one way of doing that is engaging in a telehealth model, whereby you leave everything up to the community person or the pharmacist, and really, a doctor signs off after a checklist is filled in, for example. I think but we have laws within our countries, and the laws are there meant to be respected, but but they are there to be challenged and move the pole again. So anyways, I just think that should also be a common theme here. And I think Andrew may have a lot of examples from his setting where they do that, because I think that's where they do it the best, right. So maybe that's 6:24. So Emma, I'm supposed to then now move to all of you, and I don't know whether I've done this right.
No, it's all good. It's the discussion's been fantastic. I think there's a couple of questions in the chat, but people are also jumping in and responding there. So but I think if there's additional questions, people can feel free to raise them.
I wanted to ask.
Go ahead, please, Andrew.
I wanted to ask the colleagues on the chat, how do you envisage using artificial intelligence tools to expand person-centered care? We've heard about digital health interventions in Taiwan and in Thailand, but what do you all think about using AI to reduce barriers to care?
Yeah, good question. That's a debate question for me as well. the Singapore HIV Congress, okay? So I look forward to answers here to help me out.
Carol, you want to go start? This is your area.
We are thinking, but more like mental health support. But I think we can only say supporting, but it cannot replace the real medical care. So I think a lot of people are linking their conversational agents or chatbots with large language models and try to feed those models with the right knowledge so that they are not going to answer in a bad way. So they try to make a better answer for people. And I think everyone, not everyone, but like a lot of people are thinking about it. And our major concern is, first of all, what if the AI give you the wrong answer and people forgot to take pills or all this stuff? Or what if your AI did not provide good mental health support and people actually go ahead and commit suicide? So those are still concerns. And when we are testing this out, we just give a lot of cautions and having a human in the loop to make sure that everything goes okay. But in the future, when we get the evidence and ready to implement this in real world, I don't know how much human in the loop thing that we can do when it's out there. So it's probably going to be a concern. But right now, at this stage, a lot of people are just testing, experimenting it, and trying to improve the model with more human factor in this AI thing. But we're definitely doing it right now. That's my answer.
Do we have any other questions for each other? Can I just ask one final question then? And it's questions to Ben and he loves this question. I've noticed Andrew asked, is cost the key barrier to accessing injectable PrEP in Australia? And when I spoke to you, Ben, a couple of months ago, it was a frustration then. It seems like things haven't moved forward. And I'm just looking at countries like UK, which recently approved, I don't know, long-acting cabotegravir. They approved long-acting cabotegravir quite late compared to other countries, but I feel they are moving forward. And yet they also have problems with reimbursement of PrEP under the National Health System for many, many years. Where do you see this discussion going in Australia? And how does community leadership once again come into this?
Yeah, I think this is a bit of a depressing picture, to be honest. And it's not just Australia. I think someone mentioned the long-acting PrEP is being rolled out in the global north before, and actually that's not true. It's being rolled out in the US. The US is not the global north, right? There's all these high-income countries that are just not going to get access to these products because the way that our systems for funding medicines, because most of us have some form of socialized medicine, unlike the US, which is completely privatized. So in countries that have purchasing, the way that we purchase medicines is that our governments purchase the medicines and then the medicines become available to our populations for a subsidized price. That's certainly how Australia works. That's how New Zealand works, the UK, most of Europe, Canada. All of these countries are going to run into the same problem, which is that the drug companies will not lower the price enough, the governments, to make it cost effective for the governments. And the governments, because we have access to generic oral PrEP, will not be willing to increase the price they're willing to pay because it's just not going to be cost effective for the governments. There's just no scenario in which paying $33,000 a year is going to be cost effective. And that's how medicines are decided to be funded in our context. The only other way that it can happen is that drug companies can enter into a direct agreement with the government to say, we're not going to go through the normal system. We're just going to make an agreement where you pay a certain amount for a certain level of the medicine. And then if your community, if your public wants more of the medicine, then we as the drug company wear the rest of the cost. That's called a innovative cost sharing agreement. And that's what we did in Australia for the hepatitis C medicines, where the Australian government handed over $1 billion to Gilead so that we could have access to the hepatitis C medicines. But then the agreement was, if more people need those medicines than is covered by that $1 billion, then it's Gilead that wears the rest of the cost. But I can't see that happening with a prevention product like LEN or carbotegravir. We just can't see it. So while there's still all this talk, I think at the moment by the drug companies saying, we want this to happen, we're talking to your governments, I'm at a loss. I can't see a way forward. So I think all community really can do is continue to advocate, continue to try to push the government to be willing to pay a little bit more. We are a rich country. We should be able to spend more on medicines. And so that's the argument we're trying to put towards the government. But at the same time, the drug companies have to understand that prevention products are not the same as treatment. When you're giving people treatment, you can charge a high price because you're going for a high price, small volume. When you're talking about prevention, you need to be going for massive volume at a small price, and the companies can still make a profit. But most of these companies just haven't woken up to this fact yet.
Yeah, it is frustrating. It is frustrating. And the same probably would apply as well for other high income settings such as yours, Carol, right? So yeah, but we don't want to end on a somber note. I think there are a number of excess meetings being planned for the year for the Asia Pacific. So we look forward to that. I think so. Thank you very much, everybody, for participating. I hope I did moderation some justice. Emma, I think I went off points. But,
no, it was fantastic, and we really appreciate everyone's time today and the discussion. It's great to just see the conversation come alive. This is really the goal of these research collaborative meetings. So we will continue to convene on different topics throughout the year, usually around once a quarter. And then our goal is by the end of this year to publish a research agenda on person-centered care to further guide research in this area. So thank you all for your contribution and have a lovely rest of the day.
Thanks, everyone.
Thank you.
Thank you.
Thank you, everyone.
Bye-bye.